Hello and welcome to the Legal Edition. I'm your host, Attorney Mary Kay Elloian. Our topic today is the Affordable Care Act. Will Congress extend the subsidies, making health insurance affordable again? Our guest is Elizabeth McCuskey. She's a professor of health law policy and management at BU School of Public Health and BU School of Law. She is also assistant director of the Center for Law, Ethics, and Human Rights. Her research and authorship focuses on ways state and local governments pursue legal reforms that promote health equity, insurance, and access to care, and how courts intervene in these relationships. Let's welcome Professor Elizabeth McCuskey. Welcome, Professor McCuskey. With the current situation now in Washington, D.C., what do you have any feelings how this is all going to fall out with regards to this whole entire fight over the ACA?
I think some of it rests on the consequences of what Congress is debating. And so what they're debating is whether to keep a higher level of subsidy that was set during the pandemic that made insurance more affordable for a lot of people, or whether to let it expire on December 31st. So during the pandemic, people lost their jobs, but we really needed people to be on insurance. So part of the American Rescue Plan was to give a higher rate of subsidy and to make sure that we didn't just cut people off once they hit 400% of the federal poverty level, which for a household of four is like 32,000, is $128,000. So the enhanced subsidies were designed to get more people to have insurance. But politically, the Congresses during that time set an expiration date. And so currently, those subsidies will expire. Practical impact for an individual buying insurance on the Massachusetts exchange would be if they made the median income of Massachusetts like $46,000, buying a regular plan, it would be $800 a month without the subsidy. It would be about $221 a month with the subsidy. If Congress does nothing and lets that enhanced version of the subsidy expire, then the exact same plan for 2026, so what we're signing up for now, would go from $221 a month up to $375 a month. So the way that the subsidies are calculated, the rules that go with them, really impact the affordability of plans. And that has been one of the big subjects of the government shutdown that just ended and is currently still part of the debate about the bill and budget going forward.
Mhm. Is there a threshold to, I think you had mentioned there was a threshold if someone makes over a certain amount, the subsidies are shut off, or
Yes.
can
So the
you?
way the Affordable Care Act is written, people between 100% and 400% of the federal poverty level are eligible for subsidies. 400% of the federal poverty level is, let's say, for an individual, I think it's like 62,600. So under the ACA as written, if you make $62,700, you get zero subsidies.
So you
So
shut
that's
off
called the
completely.
cliff, right?
Yeah,
Um,
it is a cliff. I mean, it doesn't
it's a
like
cliff.
taper off. It just, you get nothing.
So the percentage of income that the subsidy applies to is a sliding scale from 100 to 400, but at 400 it stops. So people were falling off the cliff quite a lot. So the American Rescue Plan revision of the subsidies that expires December 31st ended the cliff, and instead said the subsidy will bring the premium down to no more than 8.5% of your income, whatever that is. So middle income people above 400% of the federal poverty level, if they lived in a place with really expensive insurance, would still get subsidies because that really expensive insurance would eat up more than 8.5% of their entire household income.
Mhm.
If it is allowed to expire, we go back to the 400% of the federal poverty level cliff.
And what does that mean in dollars? So if somebody's making $5,000 a year, where does that leave them for payments before and after?
So if you're close, right? So if you're making $60,000 and you're at the edge of the cliff, the enhanced premiums that expires on December 31st would bring you down to would be about like $300 a month.
Hmm.
Um, and if they expire, it'll go up to $490 a month. It's still quite a substantial increase.
Yeah. Well, let's hope Congress does the right thing.
Gotta have this discussion sometime.
Right.
So they may kick it down the road. Um, but that would at least keep insurance affordable for people and not get them caught in this very urgent and preventable kind of economic situation.
Yeah, because they're getting their bills right now. And, right now, this is the time of year for getting the premiums in order for next year.
Exactly. It's open enrollment season, so people are supposed to be shopping for their insurance right now. It could not be a more timely or a more disruptive debate to be having at this moment.
Now, how does the ACA health pool and the providers, how does that all work?
So the ACA's individual market pool is the place where people who don't have employer-sponsored coverage and don't qualify for Medicare or Medicaid can shop for insurance for themselves or however many people are in their household as dependents. It's a federal and state regulated platform that has health insurance that meets federal standards that the Affordable Care Act set. So all of the insurance that's available to individuals who are shopping on healthcare.gov or their state version of it are qualified health plans under the Affordable Care Act, meaning that they cover all 10 essential health benefits, that they cover preventive services without a cap and without copay. They cover pre-existing conditions, and they can only charge people higher premiums based on one of four factors: age, number of people on the policy, geographic region, and tobacco use.
Hmm.
Without those rules, an individual who was going to Blue Cross Blue Shield or any other insurer and trying to buy a policy from them, the insurer could write the policy, offer it to the individual, and it could maybe not include those things, or it could exclude pre-existing conditions. So the marketplace has regulated, standardized insurance that covers all of those essential health benefits and those important things. Importantly, insurance that covers the things that you need, that covers all those essential health benefits, costs more than insurance that does not cover all those essential health benefits. So on the exchanges, people who shop there are eligible based on their income to potentially receive federal subsidies. These are the premium tax credits, which is a federal payment that pays a portion of the premium to make the policy affordable for the person. So if the
I just want to say, I think people have a little bit of misunderstanding about the ACA. What my view it has done is set the standard, not only for those that have the ACA coverage, but set the standard for everyone for pre-existing conditions. Am I right or am I incorrect?
so there are a couple things that the ACA did for all insurance, not just the insurance that you buy on the exchanges. So even if you have employer-sponsored insurance, all insurance has to cover preventive care without a copay. And policies cannot exclude pre-existing conditions, and they can't refuse to sell insurance to someone who has a pre-existing condition. So the majority of that is through the exchange market. That's where most people would previously have been denied insurance based on a pre-existing condition. In employer-sponsored insurance, your employer-sponsored insurance already couldn't exclude you for a pre-existing condition. So when the ACA regulated private insurance, so employer-sponsored insurance and individual private insurance. It did create this standardization. Federal regulations, federal uniform regulations for insurance. But I do want to note, this is why the ACA is sometimes hard to understand. There's a lot of detail and there are a lot of exceptions. Those 10 essential health benefits that the ACA says insurance has to cover, only the plans that are sold on the exchanges have to cover those 10 essential health benefits. If you buy an insurance plan, not on the exchange, just on your own, the insurer does not have to include all those essential health benefits. If
Can
you're
you give us
shopping
an
on the
idea?
exchange, you know it will be covered.
Can you give an idea what those 10 benefits are?
Yes. They are outpatient care, emergency care, hospitalization, maternity and newborn care, mental health and substance use disorder services, prescription drugs, rehabilitation, labs, pediatric services, and preventive services.
Okay. And before the ACA, how were preventive how were pre-existing conditions treated, both in the ACA and outside? Give us a little view of both.
So before the ACA, the ability of insurers to exclude pre-existing conditions led to essentially the crisis in medical bankruptcy that prompted Congress to act and pass the ACA. So before the Affordable Care Act, insurers could dictate many of the terms of the policies that they offered individuals. They could do several things that were bad for pre-existing conditions. Number one, they could just refuse to sell you insurance if you had a pre-existing condition, even if you could pay for it. Number two, if they would sell you insurance and you had a pre-existing condition, they could charge you a very high premium because you have pre-existing condition. So they might, this is like medical underwriting. Basically, you pay based on your pre-existing condition, not other factors. So that might make it far too expensive for anyone with a pre-existing condition to buy insurance. And number three, even if they would sell you insurance and you could afford to pay for it, the policy itself could exclude coverage of your pre-existing condition.
Wow.
There are a couple other more detailed things that affect pre-existing conditions, but those were the big ones.
Wow. So that's a big one because there's a lot of people, small business people, that will even buy on the ACA. That's my understanding. So it's not just, the very poor. There's the middle of the road people as well that are middle class. Or uh, tell us a
So
little bit about who you've seen actually sign up for the ACA.
so when we're talking about the ACA, we're talking about the exchange plans here.
Yes.
For the very poor, only Medicaid is available. Um, the exchange subsidies start at a certain level of income, and people below that income are not eligible for subsidies. But so the folks who are on insurance that they bought on the exchanges, it's a lot of people. So I think about 21 million people were on exchange insurance in the last cycle. I think in 2024, about 21 million people had their insurance through the exchanges. Um, the vast majority of those people, probably around 90%, have incomes low enough to qualify for a federal subsidy that brings down their premium. So these have to be people whose employer doesn't offer them insurance. So wage and hourly workers, people who have two part-time jobs and so don't qualify for full-time insurance, employees of small businesses who don't have to offer or can't offer insurance, would shop on exchanges, and self-employed folks, right, who that's where they would get their own insurance and the insurance for their household.
And when you say
Um,
that, you mean small business owners.
and many small business owners, yes.
Yes, yes. So it runs the gamut for who can get into the exchange.
Yes.
Now, on that same vein, do you have to be a citizen? Because there's a lot of talk about people who aren't citizens that are gaming the system. Who have you found can be on the system?
Um, so you are, first of all, you're not eligible for subsidies if your employer offers you insurance. Um, Second, if you're so low income that you qualify for Medicaid or CHIP, or you have a Medicare plan, you don't get subsidies on the exchange. Um, uh, Undocumented immigrants cannot receive federal subsidies on the exchanges. Some states offer their own subsidies to certain categories of undocumented immigrants, but there is no federal money available to undocumented immigrants on the exchanges.
Well, that's a
Various
very
other, go ahead.
important point. That is a very
Yes.
important point because there's a lot of misinformation on that particular point.
And I think most of the concern about the exchange insurance, certainly right now or this year, is really about who gets the federal subsidies on the exchange, not necessarily who is just generally allowed to buy on the exchange. So so people can buy insurance on the exchange, but they may not qualify for subsidies. So if you're an undocumented immigrant, you cannot qualify for subsidies. If your employer offers you insurance, you cannot qualify for subsidies. So you would have to pay full freight if you were going to buy that insurance.
So what you're saying is an undocumented immigrant can buy on the ACA, on the exchange, but they can't get a subsidy, period.
Yes.
Okay. Thank
Yes.
you for clarifying that because again, there's quite a bit of misinformation on that particular point. All right. So now that we've determined who's on it, and we've determined, we talked a little bit about pre-existing and what about states? States are signing on to some of these programs. Can you talk a little bit about what states are doing?
Yes. So as the ACA was actually designed to give states considerable control over their exchanges, if they want it. So if they don't want to participate as much, a state can just defer to healthcare.gov and the federal government runs their exchange. So what states can do is they can add protections to the plans sold on the exchanges in their states. So a state could require that insurance sold to individuals and their families cover more things than just the essential health benefits.
Mhm.
Um, so the insurer who's selling on the exchange has to comply with both federal law to get onto the exchange and state law to sell policies to those states' residents. States can also supplement federal policies but they have to pay for it themselves.
Mhm.
So, for example, Massachusetts does offer some additional subsidies. So they go above the federal income cap, and they have some help available for undocumented immigrants, but that is entirely out of the state budget. It is not using federal funds.
Mhm. What states or what percentage of states have some kind of program? All of them have access to the exchange because it's a federal program. Am I correct? But some
Yes,
states don't offer a state program. Can you tell
correct.
us what states and or what regions of the country that occurs?
Um, I can try.
I mean,
Um,
generally.
right, and so it's different each year, and there is both there's a political and a financial and an administrative calculation that states need to do. I think we're up to 20 states who run their own exchanges. Um, the but I don't remember exactly what the list is.
Yeah.
Politically, at first it was states who wanted to resist the Affordable Care Act would default to the federal exchange. They would not set up their own exchange because the legislature or the governor of that state did not want to actively participate in implementation of the Affordable Care Act. Um, So it's really state by state, year by year, political and financial calculation, but a state that runs its own exchange has more control over how that exchange operates.
Mhm,
And they can get technical assistance from the federal government to do that.
mhm. Do you find that the political divide with regards to what states offer? Do you see that occurring?
Um, yes, and that tended to be true before the Affordable Care Act as well. States that have richer, more diversified economies um, have more right, money to spend on policy. And it has long been a more liberal or progressive priority to have meaningful insurance to make sure that health insurance covers what people need. That of course raises the price, right? So it's better insurance, so it costs more. So there is a very red-blue divide in kind of state insurance mandates. And certainly after even before um, uh, Dobbs versus Jackson Women's Health, many states require all insurance sold in their state to cover abortion, and many states prohibit any insurance from covering abortion in their state. So there are a lot of political and kind of like culture war topics that actually play out in state regulation of insurance.
Mhm. Which makes it hard for women to navigate, I'm sure.
Yes.
Yeah.
And if you have employer-sponsored insurance, you don't even get to pick the insurance at all. It's your employer deciding what plan and what state.
Yeah, I find that one terrible.
That's maybe another episode.
Yes, exactly. Talk about no choice. And and I've been reading recently some of the judicial rulings with regards to the Consumer Protection Bureau. I've seen that now medical debt can go back on credit reports. There was a ruling before that wasn't going to go on reports, but just recently a Texas judge said, yes, the Consumer Financial Protection Board overstepped their authority, and now it's all fair game. And it's really sad because people go bankrupt, and you know. And one of the other things that I think you wanted to talk about is maybe the rural hospital closures because of some of these cuts.
It's quite a house of cards that the U.S. healthcare system has that kind of riding on insurance. Um, And all of these policy questions, including the impact that medical debt and medical bankruptcy has on non-medical aspects of life, are a really important reason to care about how many people are uninsured. Um, and let me also note, it's not just uninsured, not having insurance. People could have insurance that doesn't cover what they need.
Underinsurance.
We call that underinsurance, right? That can lead to medical debt and medical bankruptcy almost as quickly as uninsurance. So with the question about like what impact might this have on hospital closures, particularly in rural areas? Um, Insurance is right how hospitals get paid for doing the amazing, intensive, and often very expensive care that they provide. Um, if fewer people have a source of payment to go with that for their medical care, then hospitals have a much harder time keeping the lights on, getting enough revenue to operate. And that's additionally because we do have one rule in the United States called EMTALA, which is any hospital that accepts Medicare and Medicaid and has an emergency room has to take people who are in an emergency medical condition and treat them before asking whether they have insurance.
And that's before asking them whether they're a citizen or not, correct?
So I'm not sure what the protocol of questions are.
Mhm. Yeah, I think they have to admit anybody that comes to their door just to stabilize. Um,
Yes.
but again, that's a program for another day.
Yeah.
But the bottom line here is that if you have people that are here and they're sick, it affects everyone. insurance is a pool, and you have the low incidence of illness here, high incidence here, and the median comes about to moderate the risk. So, and the risk is associated with the costs. Is that correct?
Yes. Yes. The basically, if you think about like the risk to hospitals, the risk is that they have to provide care and they can't get compensated for it, and therefore they don't have enough revenue. Right? The risk to individuals is that they will not receive care in a timely manner or at all, solely because they don't have access to pooled funds.
Mhm.
The risk to the insurer is they would have promised to pay for too many things and not collected enough money, either because they have too many sick people in their pool and they weren't anticipating that, or because prices rise. So there are different versions of risk that are all interconnected between
Mhm.
providers and patients and their insurers.
Mhm. And the bottom line is, if hospitals don't get reimbursed, they go out of business. And the ACA, as far as my understanding was, helped to keep the hospitals afloat because of the revenue stream.
Yes, it was actually, and it's two sources that the ACA helped prop up, particularly for rural hospitals. So one are are individuals who are buying their own private plans, or else going uninsured. And the other were people who don't even have enough money to buy a private plan at all. And that was the Medicaid expansion. That was the intention behind the design of the Medicaid expansion.
Right, right. And not all states have expanded that.
Correct.
Mm. Do you know roughly how many states have
I
the
think we're
Medicaid expansion?
I think we're up to 40 for the Medicaid expansion.
So it's more than it used to be, but
Yes.
still a ways
More
to
every
go.
year. Seems like a better idea every year.
Yeah. So is there anything, any other reasonings or rationales behind the Affordable Care Act and the subsidies that you want people to know about?
Um, one more thing is the connection between a state's decision to expand Medicaid, and people's ability to buy insurance on the market on the ACA exchange. So the design of the Affordable Care Act was intended to try to get as many people covered by some source of insurance as possible. And so it started with $0, people who have absolutely no money. Um, and it expanded Medicaid to cover people solely based on their income and not based on their income plus having some kind of disability. So the intention was everybody under 100% of the federal poverty level, which is set each year, would be eligible for Medicaid. It would be a program designed for the low income. People at 100% and above would need to buy their own private plans, but they couldn't probably afford it. That's why most people didn't have insurance in the lower and middle class. So the exchanges would give them insurance that covers pre-existing conditions and the opportunity to have federal subsidy bring the cost down.
I've learned quite a bit, and I look forward to continuing this conversation. This is an evolving issue um, with the current atmosphere in Washington, D.C. So we'll find out how all this falls out. Well, it was a pleasure meeting you, and thank you again.
Pleasure meeting you. Thank you.
I want to thank our guest, Professor McCuskey, for sharing her insights and opinions on the Affordable Care Act and issues surrounding the ACA subsidies. I also want to thank you, our viewers, for tuning in. For more information on today's topic and our guest, visit us online at thelegaledition.com. As always, this information is for general educational purposes. It is not to be construed as legal or personal advice. So please seek a qualified practitioner as to your own legal or personal needs. And don't forget, subscribe online. Find us on Substack, YouTube, Facebook, Instagram, and now Blue Sky.